Good evening, everyone. Welcome to the live session class for the PG Medicine Residency program. I'm really happy to see all of you here this late in the night. I really know that all of you are really tired after the busy schedule, busy residency work. But uh, I'm really happy to see that all of you are so keen to learn this late in the hour. So let's begin. Today, we are going to learn about sepsis. And I would like to disclose the fact that I'll be showing some patient videos. And for the same, I have obtained written consent from the patient party. And I will be sharing only the relevant details, the clinical examination, the complete examination, and many of the laboratory reports will not be disclosed here. And only relevant thing that we need to have the take home points will be shared here. All right. So let's begin. Now, why I have chosen this topic of sepsis? Every year, according to WHO, 48.9 million patients suffer sepsis. And out of this, 20 to 30 percentage of ICU admissions are because of sepsis patients. Now, sepsis is said to be a medical emergency because it is associated with 10 percentage mortality and a subset of sepsis. That is, if the patient goes into septic shock, the mortality is going to be really high as 40 percentage. Every year, 11 million people die because of sepsis. And this is one of the most common conditions, most common emergency or critical ill condition that you are going to manage in your residency. Every day you will be seeing at least one patient, and in your residency you will be managing almost hundreds of patients. All right. So this is a very important topic. All right. Now this is one of the latest guidelines. Okay, it was published in 2021 only. I'll be basing a lot of topics based on sepsis based on this article. All right. Now this was produced by the Society for Critical Care Medicine, and every 4 or 5 years they have brought out the Surviving Sepsis Campaign guidelines. The first one was published in 2004, and the recent one was published in 2021. Okay. Now, during your residency, you will be hearing about a lot of these kind of guidelines. One thing you need to understand is that every guideline should be used just as a tool. Okay. See, most of these guidelines are made of evidences, which is up to that time. All right. And after that, a lot more evidences might be coming out. Okay, and the guidelines, you know that they can vary, they can change every time the evidence changes. Okay, for example, some therapy which has been found useful like 5 years back may be proven to be more harmful after 5 years of research. Okay, So, and another thing is that there can be a lot of bias when you are taking these sort of guidelines into your practice. All right, because most of these guidelines are uh, put forward based on evidences, usually based on studies conducted in Western countries, okay, in the Western population. And it may not be exactly applicable to our population. And the socioeconomic status, the cultural status, all these things matter. All right. All these differences matter when taking care of individual patients. So these guidelines will be just like it said, they are just guidelines. Okay. They can guide your treatment when you are asked on what basis you did such and such therapy, then you can rely, or this is sort of a proof, or this can support your decision making. All right. But for individual patient management, you will have to follow something called as a personalized medicine. All right. These guidelines will be helpful, but mainly they are for the global population. They are meant for the global population rather than just an individual patient. Okay. Now we will be discussing sepsis under based on three cases which I have managed in the last 1 month. Okay. I think most of these three cases will be able to bring out most of the important concepts that we need to know about sepsis. All right. So the first case is a 70-year-old female. Now she presented to our emergency department with complaints of fever and vomiting for 4 days duration. And she has been complaining of breathing difficulty since the last night. Now, she is a non-case of bronchial asthma. She is a chronic bronchial asthma patient since childhood. She also has history of diabetes, systemic hypertension, and she was recently admitted within a month's period of time for a diabetic chorea episode. All right. She is unmarried mainly because of her underlying bronchial asthma condition, and she was living with her brother as well as sister-in-law. Okay. Now, this patient, even though you can see that she is smiling, she wasn't saying much complaints. Okay, some patients are like that. But the brother as well as his sister-in-law were saying that this patient was having severe breathing difficulty and she wasn't sleeping the night before she came to the emergency department. Okay, that's very important, whether the patient was able to sleep in the night, okay, before the coming to the emergency department. All right, that can tell you a lot of things. Okay, and you can ask about history, whether the patient is able to have adequate oral intake, whether the patient is having any altered sensorium, whether the patient was having bedwetting. Okay, these are all clues that the patient could be having a serious condition. All right. Okay, this patient has been on Foracout MDI, which is formoterol and budesonide. She was also on Mucinex AB, which is acetylcysteine and acetylpropylene, levocetirizine, amlodipine, metformin, glycoside, and linagliptin therapy. Okay. Now, on arrival in the emergency department, she was maintaining the airway. Her airway was clear. You can see she's talking almost in full sentence. Her respiratory rate was 30 per minute. When she came to the emergency department, her room air saturation was only 78%. Okay, so we started her on oxygen using a 4 liter at a flow of 4 liter per minute using nasal prongs because I was suspecting whether this patient was in fact having bronchial asthma or whether there is an overlap syndrome of COPD along with bronchial asthma. All right. And her saturation actually improved with 4 liter per minute oxygen to up to 97%. And she was able to speak in full sentences. You can see in that video. All right. She had mild wheeze bilaterally on auscultation, and crackles were also present bilaterally, crackles or crepitations. Okay. And these were more in the left infraclavicular area. Now she was having a heart rate of 156 per minute. Her blood pressure was on the higher side, 166 over 100 millimeters of mercury, with a map of mean arterial pressure of 126 millimeter mercury. Her GCS was full. She had no focal neurological deficits. Her GRBS was on the higher side. It was 311. Her temperature was normal initially. Later, after about 3-4 hours, she had a increase in the temperature, and which was about 102 degrees Fahrenheit. All right. She was having mild pallor, no pedal edema, and there was no rashes. You can see her vitals on this monitor here. Okay. Now, the concerns for me when I saw this patient was that, of course, she is in acute hypoxemic respiratory failure. Okay, AHRF. All right. Now, what's the underlying cause for this? Whether this was an infective exacerbation of severe bronchial asthma because the patient was having underlying asthma, chronic asthma was there, and now she was complaining of fever as well as vomiting. So whether there was an underlying infection, like it could be an upper respiratory infection, maybe even a urinary tract infection, which could have precipitated the asthma exacerbation right now. All right. Now, because the patient was having such a low saturation, of course, it has to be a severe bronchial asthma, or there could be other conditions which could be causing a shunt phenomena here. All right. So for such patients, it could be either pneumonia. You need to suspect that, okay, which could be causing a shunt phenomena and ventilation perfusion mismatch, which is responsible for such severe hypoxemia. All right. Usually, bronchial asthma patients coming with such low saturations, they will be looking really sick. They will be having severe respiratory distress. Okay. Now, if there is pneumonia, whether this patient is having severe pneumonia or even amounting to sepsis, all right, that's what's a concern for us because sepsis, that means a higher mortality. This patient has to be managed immediately. All right. Now, whether this patient is having hyperglycemia and whether that is producing diabetic ketoacidosis, we need to find out. Or is there any associated heart failure, all right, which could be contributing to the severe hypoxemia? So those are some of the concerns immediately. All right. So anyway, we are trying to manage it as a bronchial asthma exacerbation initially. So patient gets oxygen, which we have already started. Of course, nebulizations with bronchodilators were given, back-to-back nebulizations were given, and of course, steroid IV hydrocortisone also given. Now, even after all these therapies, the patient's respiratory distress actually didn't have much improvement. All right. So whether we should start this patient on non-invasive ventilation and whether we should start this patient on antibiotics, which antibiotics should be given, and whether this patient should be given IV fluids and how much IV fluids, which kind of IV fluids should be given. We know that the patient has been vomiting for last 4 days. There is decreased food intake, and the patient has been even on inquest. The patient was saying that there was a decrease in the urine output as well. So whether we should give IV fluids. Okay. Now, to find out these things, of course, we will go for investigations. And the most important ones we have at the bedside itself. These are called point of care tests. All right. These include the ABG, arterial blood gas analysis, ECG, point of care ultrasound, which is called by the acronym POCUS, then portable chest X-ray, then blood ketones. All right. All these can be done at the bedside itself. Then, of course, we'll be sending for other laboratory parameters like CBC, CRP, RFT, LFT, serum electrolytes, including calcium, magnesium, phosphorus, then coagulation parameters like PTINR and EPTT, then urine analysis, and blood culture and sensitivity, whether it's required, even for severe pneumonia, and even if you're suspecting sepsis, you need to send appropriate cultures. All right. And for this patient, a blood culture and sensitivity, and maybe a sputum culture and sensitivity. But I won't be sending that from the emergency department. All right. Because it has such a low yield, very poor sensitivity as well as specificity. All right. Now you can see this is the point of care ultrasound finding. All right. And I am examining actually the left anterior zone here. Okay. And what you're seeing, it might be a bit hard for you to make out the structures here. All right. I'm looking for the lung here. I'm doing a lung ultrasound here. And what you're seeing here actually is the hepatization phase of the lung here in pneumonia. Okay. You can see the lung here. This is the lung. And you can actually see the white echogenic structures here. That is actually the air bronchogram, all right, of pneumonia, the classic description of pneumonia there. Okay, and this is the picture of a liver which looks in the ultrasound. And in the hepatization phase, during ultrasonography, the lung will be looking exactly like the liver here. All right. And in the right side, usually these are the zones that we are scanning using the lung ultrasound. We are using, I'm using an echo probe here, but you can use the abdominal probe or even a linear probe also, or the high frequency probe, all right, for doing lung ultrasound. Other findings were that LV, the left ventricle, was hyperdynamic. There was no LV systolic dysfunction. Okay, hyperdynamic is usually seen in sepsis and hypovolemic states. All right, and the patient's IVC, inferior vena cava, was also collapsed, completely collapsed. That tells me that this patient is hypovolemic. All right, and this patient can tolerate some fluids. Okay, so even before getting a portable chest X-ray, we confirmed by bedside ultrasonography that this patient is having severe consolidation and is having pneumonia in the superior lobe of the left lung. All right. Now, the portable chest X-ray was taken to confirm this. You can see that there is a homogeneous opacification here involving the left upper zone as well as the middle zone. And on the right side also, you can see that there is some non-homogeneous opacities or infiltrates in the right upper zone as well as extending to the middle zone here. Okay, you can see that. All right. So this confirms that this patient is having pneumonia. Now, how severe is this? And is the patient going into sepsis? That's what we need to find out. All right. So we got an ABG for this patient, and also to find out whether this patient is having a hypercapnic respiratory failure, whether the patient is going into respiratory fatigue. In that case, we need to provide ventilatory support. Okay. But luckily, you can see that the PCO2 here is 30.9. All right. So the patient is having respiratory alkalosis. If the PCO2 was normal, or even patient is having respiratory acidosis at this higher respiratory rate, which was, if you remember, it's 30 per minute, I would be really worried because the patient is going into type 2 respiratory failure, or what we call now as hypercapnic respiratory failure. And the patient requires immediate ventilatory support. All right. And for a patient who is having pneumonia and hypercapnic respiratory failure, intubation and invasive mechanical ventilation should be or would be the ideal choice. All right. Now, other things to look for, this patient is having metabolic acidosis here. What could be the reason for that? And you can see there is lactic acidosis also here. All right. So lactate of 5, this is very significant. Okay, because lactate is a prognostication marker as well. If it is above 4, the mortality is going to be very significantly high. All right. These patients require ICU admissions and they need aggressive management. Okay. Now, what could be the reason for the metabolic acidosis here and the lactic acidosis here? So we know that the patient's blood glucose was high. It was more than 300. So could there be DK, diabetic ketoacidosis? So when we looked at the blood ketones, it was actually negative. All right. So then what could be the reason for this acidosis? Now, whether this patient is having an AKI, all right. So in AKI also, you can have metabolic acidosis. In a renal failure, you can have metabolic acidosis. Okay. And this is also a high anion gap metabolic acidosis. You can see the anion gap here is 19.7. All right. Okay. Now, the question obviously comes, is there sepsis? All right. So for this, how do you define sepsis? That's the first concern for us. So the definition of sepsis also has been evolving over the last couple of decades, and the currently followed definition was actually put forward in 2016. This is called as a sepsis 3 definition, or the third international consensus definition for sepsis and septic shock. Okay, I would highly recommend all of you to go through this paper. All right. It tells you how this definition came into being and the main pathophysiology, our understanding about the pathophysiology of this condition. All right. Now, according to sepsis 3 guidelines or definition, sepsis is a life-threatening organ dysfunction due to dysregulated host response to an infection. So you need three parameters or three criteria to be satisfied to diagnose a person to be having sepsis. All right. First of all, there should be an infection. Okay. An infection which should have resulted in a dysregulated host response that in turn causes a life-threatening organ dysfunction. All right. So those are the three things. An infection should be there. So evidence of infection, you need to look for that. And a dysregulated host response should be there, which should be causing a life-threatening organ dysfunction. All right. And the most crucial thing for us is that there is no gold standard test to diagnose sepsis. Okay, so a lot of clinical as well as laboratory parameters are put together to make the diagnosis of a sepsis. All right, and to understand or to find out this organ dysfunction, the sepsis 3 guidelines, they are actually recommending to use the SOFA score. Okay, SOFA score is sequential or sepsis related organ failure assessment score. All right, SOFA score has been used in the ICU setting even before it has been recommended for the usage of sepsis. Okay, now SOFA score is actually a prognostication marker. If the SOFA score is high, it actually predicts the mortality in ICU patients. Okay, so sepsis 3 guidelines, they are recommending that if there is an increase in the SOFA score by 2 or more, along with the other things, that is, there should be infection, which should lead to the dysregulated host response, then only you can diagnose this as sepsis. Okay, so you need to find out what's the SOFA score of each of these patients if you are suspecting sepsis. All right. Now, in sepsis, there is a mortality of up to 10%. Okay, greater than 10%. Now, they also defined septic shock. Septic shock is actually a subset of sepsis, all right, in which there is profound circulatory, cellular, and metabolic abnormalities, and it is associated with a higher mortality of up to 40%. Okay, now how you clinically diagnose septic shock is that you need to have the patients with sepsis who have a MAP less than 65, and these patients should require vasopressors to maintain a MAP greater than 65 millimeter of mercury. Okay, and along with that, they should have a lactate which should be more than 2 millimoles per liter. And all this should be present in the absence of hypovolemia. All right. So if a patient is having a MAP of less than 65, see, why are they using MAP? All right, because we know in most of the ICUs and in nowadays in emergency departments, we are using non-invasive blood pressure measurement, right? And in that, the principle of oscillometry is being used. Now, oscillometry accurately measures the mean arterial pressure. Okay, so whatever NIBP that is being reported there, the mean arterial pressure is much more reliable. Now, the systolic blood pressure as well as the diastolic blood pressure is actually derived from this mean arterial pressure in non-invasive blood pressure monitors. Okay. And also, mean arterial pressure is more important when you are considering end organ perfusion. For example, if you look at the cerebral perfusion pressure, it is actually mean arterial pressure minus intracranial pressure. Similarly, is for the renal blood perfusion pressure. All right. So mean arterial pressure makes much more sense when using using any criteria to diagnose septic shock. All right. So first of all, if a patient is having a mean arterial pressure or MAP less than 65, you need to see if there is hypovolemia. And if there is hypovolemia, you need to correct that first. All right. Despite correcting the hypovolemia, if the mean arterial pressure is less than 65, then you need to start these patients on vasopressors. Obviously, you need to start these patients on vasopressors because at least a MAP of 65 is required for end organ perfusion, proper end organ perfusion. All right. So if you are starting vasopressors and if the lactate is more than 2 millimoles per liter, then you can say that this patient is having septic shock. All right. I hope that is clear. All right. Now let's take a look at sepsis in detail. Okay. So I have already mentioned we need to look for the sequential organ failure assessment score or the SOFA score, right? Now, what are the components of SOFA score? It has 6 components, all right? It has a cardiovascular component, CNS component, respiratory component, coagulation parameter, liver, as well as kidney. Okay, now each of these parameters, based on the severity of dysfunction, they are scored from 0 to 4, all right? So if you look at this, if the patient is having less than 9 as the score, if you calculate the entire score, if it is less than 9, I already told you that it is a predictor of mortality. Okay, SOFA score is a predictor of mortality, right? So if the score is less than 9, patients can have a mortality of less than 33%. Now, as the score increases to 9 to 11, the mortality increases from 40 to 50%. And as the score increases to more than 11, more than 95% mortality. Okay, so it is a good predictor of mortality, SOFA score. All right. Now, if you look at the components, how to remember the components, this is something very important. Okay, so I use a head-down approach to remember it or a top-down approach. First of all, in the head, the CNS, we use GCS score. All right. Now, coming to the chest, you use in the respiratory system, you use the PF ratio. Okay. And PF ratio requires, of course, an EBG, right? Now, in the cardiovascular system, you are looking at the mean arterial pressure. Remember, it's the mean arterial pressure, not the systolic blood pressure or not the heart rate. It's the mean arterial pressure. And the requirement for vasopressors to maintain the mean arterial pressure. Okay. Now, coming to the coagulation system or coming to the blood in the cardiovascular system, you are looking for the coagulation parameters, especially the platelet count. Okay, it's not the INR. We are looking at the platelet count only. And anything less than 1.5 lakh is given a score of 1. All right, it starts with 1 if it's less than 1.5 lakh. And if it is less than 1 lakh, a score of 2 will be given. All right. So platelet count is also very important to assess whether the patient is having sepsis. All right. Now coming to the abdomen, you are looking at the liver as well as the kidneys. In the kidneys, you are looking for the creatinine as well as the urine output. Okay, so either creatinine or the urine output can be used. And in the liver, you are looking for the bilirubin value. All right, so you can see that there is a lot of laboratory parameters here. All right, so the platelet count, the bilirubin value, the creatinine value, as well as the ABG is required for calculating the PF ratio. At least 4 laboratory values are here and only 2 clinical parameters, which is actually the cardiovascular, the blood pressure, as well as the mean arterial pressure, as well as the CNS GCS score. All right. So whenever a patient comes to the emergency department, we will have to do all these investigations and the reports are going to come in some time only. They are going to take some time, right? In most of the laboratories, it will take around 1.5 to 2 hours to get these reports, if it's not more than that. All right. So the problem is that there can be some delay in identifying sepsis in these patients. Okay. So even if you are suspecting infection and whether to do all these tests for all these patients with infection, that is also another question, right? We do not do all these tests for any patient coming to us with any kind of infection, right? And for that itself, the sepsis 3 guidelines, they are actually recommending that we should use something called as a QSOFA. That is an acronym for quick SOFA, quick sepsis related organ failure assessment score. And the variables in that include altered mental status, tachypnea, as well as hypotension. Okay, so if the patient is having a GCS of less than 15, 1 point will be there. Tachypnea, respiratory rate more than or equal to 22, you can add 1 more point. And if there is hypotension, here you are using systolic BP. Okay, this is used as a screening tool. Okay, so you can use systolic BP. If it is less than or equal to 100 also, you can add 1 point. And you can see that if the total points is 2 or 3, there is high risk of poor outcome. Okay, so as sepsis 3 guidelines, they are recommending to use this QSOFA. So if the QSOFA is more than or equal to 2, then these patients should be evaluated for sepsis. All right. So any patient coming with infection, having altered mental status or low systolic BP or tachypnea more than 22, per minute should be evaluated for sepsis using the SOFA score. All right. Okay. Now, you can see another limb here in the algorithm. What if QSOFA is negative? All right. If it is no, and if you're still suspecting sepsis, you can again evaluate the patient using the SOFA score. All right. So why this limb is here? This is because QSOFA is not a very sensitive tool. All right. In fact, it is not at all sensitive compared to other tools. Okay, for screening for sepsis. All right. Now, the important thing you need to know is that when the sepsis 3 guidelines or recommendation were produced in 2016, actually QSOFA was validated as a tool for predicting mortality rather than as a screening tool for sepsis. Okay, so after that, they actually did a lot of studies which showed that QSOFA as a screening tool for sepsis is actually very poor. It has a poor sensitivity and in fact the least sensitivity of all the other screening tools like SIRS, NEWS or MUSE. It has a sensitivity of only up to 54% and the specificity is also not that great. It is only 67%. But most important thing is the sensitivity. Because whenever you are screening for a disease, sensitivity is the most important thing so that you don't miss any of these conditions. Okay. Now let's look at, so this was the recommendation. Actually, this was a strong recommendation from the Surviving Sepsis Campaign group in 2021. They say that QSOFA should not be used as a single screening tool for sepsis or septic shock compared with SIRS or NEWS or MUSE. Okay, so what are the other screening tools for sepsis? We already seen the components of QSOFA as well as SOFA. Now, SIRS, NEWS and MUSE. Let's see them in detail. Okay. Now, SIRS criteria was the criteria that we actually used for diagnosing sepsis before 2016. All right. In fact, SIRS is systemic inflammatory response syndrome. Okay. It included 4 criteria: temperature, tachypnea, tachycardia, as well as total leukocyte count. That's how I remember it. 4 T's. Okay. Temperature, tachycardia, tachypnea, as well as total leukocyte count. Now, if the temperature is more than 38 degrees Celsius or even less than 36 degrees Celsius. So if the patient is having hypothermia, also it could be because of systemic inflammatory response syndrome. Okay. Now, heart rate more than 90 beats per minute, tachypnea more than 20 breaths per minute, and total count less than 4,000 or more than 12,000. Okay, or you can have immature or banned forms in the total count more than 10%. Now, if any two of these were present, they are said to be SIRS positive. They are having systemic inflammatory response syndrome. Now, before 2016, now if SIRS was caused due to positive SIRS was caused to an infection, caused because of an infection, it was called as sepsis at that time. Okay. Now, if sepsis was associated with any organ dysfunction, it was called as severe sepsis at that time. Now, severe sepsis plus refractory hypotension, that was called as septic shock at that time. Now, if there is evidence of more than 2 organ failure, it was called as multiple organ dysfunction syndrome. Now, after 2016, many of these terms were taken out. Okay, the classification is now into sepsis as well as septic shock only. There is no severe sepsis now. Okay, so either it's sepsis or septic shock. All right, so that's how the new definition is. All right. Now, if you look at the sensitivity of SIRS, it has the highest sensitivity of 91%. Okay, but you can see that the specificity is the least for SIRS. So a lot of false positive diagnosis of sepsis were made because of SIRS criteria. All right, that's why actually the sepsis 3 guidelines they were more in favor of QSOFA, but this was already proven wrong after the later studies. Okay. Now this is news that is National Early Warning Score. Now this is being followed in the NHS. All right. You can see it has a sensitivity of about 79%. Now, this is Muse. This was also produced in the, it was actually produced by a researcher in London. Okay, it is also being followed in the Europe. All right. Now, what about our patient? Coming back to our patient, because this patient was having hypovolemia, we actually gave the patient about a liter of fluid over 2 hours. All right. Now, this patient, even though after giving all the supporting medications and after giving the fluids and after giving even IV paracetamol for her high fever of 102 Fahrenheit, the patient was still having respiratory distress. Actually, her respiratory distress was kind of worsened. Okay, especially the patient after going to the toilet, she was so some kind of movement was precipitating or worsening her respiratory status. All right, so we decided to put her on NIV. All right, so whether this was an absolute indication for non-invasive ventilation, this is questionable. All right, because it is not the preferred modality for mechanical ventilation in pneumonia. But if you see the recommendation for NIV, patients with pneumonia, you can give trials of NIV for about 1 to 2 hours. If the patient's condition is improving, you may continue these patients on NIV. But if the patient's condition is deteriorating, you need to consider invasive mechanical ventilation in these patients. Okay, so this patient was improving on NIV. If you have seen the monitor, you could see that actually the heart rate was coming down. The work of breathing was also coming down for this patient. All right, you can see the heart rate was coming down to 129 per minute. All right. So we started her on IPAP of 10 centimeter water and an EPAP of 5 centimeter water with FiO2 of only up to 35%. That was enough to maintain her saturation. Okay. All right. Now, is our patient having sepsis? That's the question again. Okay, so we need to look at the other parameters as well. All right, so this patient was having a normal GCS. This patient was having a high MAP more than 70 millimeter mercury. Okay, in fact, her MAP was more than 100 when she came to the emergency department. And if you look at the PF ratio, it was less than 400. Okay, it was somewhere between 300 and 400. Okay, so this patient will get a score of 1 in this OFA system. But what about the other parameters? So we need to go for blood investigations, right? And what about the creatinine? We know that it's a late parameter of AKI. Okay, this is one of the late markers of AKI. It will take some time for creatinine to rise in AKI. All right. And urine output, actually, they are recommending to use milliliter per day in 24-hour period, how much urine is being produced. All right. And if it is less than 500 in 24-hour period, you get a score of 3. All right. So you need to monitor the urine output of also for this patient. So of course, it's going to take some time. Okay, so can we diagnose this patient to be having sepsis when the patient is in the emergency department? That's a question. All right. So you can see that this patient, you can see the total WBC count here. It was 12,390. And so if you look at the SIRS criteria, this patient is having tachycardia, this patient is having tachypnea, and this patient is having a high leukocyte count of more than 12,000 also. So if you're looking for SIRS criteria plus infection, this patient is having sepsis. All right. But that's not the sepsis 3 definition. Okay. Now you can see the first creatinine, initial creatinine, when she came to the emergency department, is only 1. But over the next couple of days, you can see the serum creatinine is rising. So we know that serum creatinine is a late marker of AKI. It will take some time for it to rise. All right. So your renal function has to be less than 50% for the serum creatinine to have a significant rise. Okay. So you can see that the patient is having an AKI as well. Okay. So now that fits into the criteria of the SOFA score. All right. Now the patient is having a diagnosis of sepsis. Okay. So this is what I want to highlight is that see the patients, all the components of the SOFA score may not be applicable in the initial visit to the emergency department itself. All right. But still, you need to suspect that these patients could be having sepsis. or some of these parameters will be rising only after some time only. All right. And the PF ratio, it might be in a downtrending manner. All right. The PF ratio could worsen over time. All right. If you are not providing adequate treatment. Okay. So you need to evaluate using the SOFA score serially. Okay. You need to measure SOFA score on a periodic basis, like at least every 12th hourly or at least every 24th hourly. You need to measure the SOFA score. All right. Okay. Now, actually, you can see the platelet count is also slightly low here. It is less than 1.5 lakh. All right. So this patient is definitely having sepsis. Now, you can look at another parameter here, which is CRP. CRP is something that we used very commonly and which got stuck with us, especially during the COVID pandemic. All right. We were using CRP a lot. All of us were using CRP a lot to actually categorize patients, COVID patients, into mild, moderate, or severe. Okay. Now, in CRP, it's an acute phase reactant. We know that it's an inflammatory marker. It is very sensitive conditions, but it is not very specific for sepsis as such. All right. So there are a lot of studies coming out that CRP is a good biomarker of sepsis in appropriate setting. Okay, if there is infection and if you are suspecting sepsis, if CRP is elevated, it's likely to be sepsis itself. Okay. But most of the guidelines, especially the SSC guidelines, is not making any comments about CRP. But this is something that we are commonly using. You can see initial CRP is more than 450. Actually, there are some studies which shows that as the CRP level is, if the CRP level is very high, it is more suggestive of gram-negative septicemia rather than a gram-positive infection. All right. So that can be kind of helpful for choosing the antibiotics also for these kind of patients. Okay. And you can see that the CRP level was coming down over the next couple of days. Okay, so this can be used as a prognostication tool as well. All right. Now, what about lactate? See, if you have seen our patient, the lactate was 5. All right. Does that have any significance? All right. Now, the SSC guidelines is saying that for adults who are having or suspected of having sepsis, we must measure lactate. Even though it is a weak recommendation, they are recommending that all patients suspecting sepsis should have that lactate measured. All right. Now, the lactate has a lot of use. We have been using lactate for a long time, but we need to know the pitfalls while using lactate, the advantages as well as the pitfalls while using lactate. Now, if you have the clinical setting of sepsis, but you are not sure whether this is sepsis or not, because you haven't got all the information, all the evidence of an infection, the blood culture reports are awaiting, but you are thinking that this is sepsis, then if the lactate is high, it points or it supports your diagnosis that this is sepsis. All right. But it is not sensitive or specific alone. So if you are using just lactate, it cannot, you cannot use, just because lactate is elevated, you cannot say that this patient is having sepsis. Lactate can be elevated because of a lot of other conditions. Patients you are using metformin can have elevated lactate. Patient having CLD can have elevated lactate. Asthma patients who are on bronchodilators, salbutamol, all beta agonist drugs, any beta agonist drugs can elevate the lactate level. All right. So it has to be used in the context of with the clinical context also. All right. Now, in the diagnosis of septic shock, sepsis 3 guidelines recommend that we have to use lactate and it should be more than 2 millimoles per liter. Right. Now, it is a powerful predictor of mortality. A lactate level more than 4 is suggestive of high mortality. Okay. Now, lactate clearance, that is how quickly lactate gets eliminated from the body, that is also helpful in guiding resuscitation. So, if your resuscitation is proceeding in the right direction, then lactate should be cleared from the body in a proper manner. All right. Now, we know that lactate actually is a marker of poor perfusion, poor tissue perfusion, or tissue hypoxia. All right. but it can be elevated in other conditions as well. In sepsis, lactate gets elevated even though the tissue perfusion is adequate because of the endotoxin inhibition of pyruvate dehydrogenase enzyme. So most of the pyruvate gets converted or diverted into the lactic acid pathway. Okay. Now, what antibiotics? This patient requires antibiotics, right? When should we give antibiotics in sepsis patients? Which one should we give? And how long should we give the antibiotic therapy? This is a very important question, right? Now, according to the SSC guidelines, see, they are saying that if sepsis is definite or even probable, or even if it is just a possibility, if shock is present, you need to give the antibiotic within the first 1 hour of patient arrival in the emergency department. Okay, this is kind of a very what would you say, very crucial or very critical saying from this, very critical recommendation from the SSC group. Okay, so within 1 hour of arrival in the emergency department, you need to give these patients antibiotics. All right, so that's why sepsis is considered as a medical emergency. Okay, now if there is no shock, of course, if you're still suspecting sepsis or sepsis is definite or even probable, you need to give antibiotic within the first hour itself. All right. But if you're not sure whether it's sepsis or if it is something else, for example, a lot of drugs can cause fever, right? Conditions like neuroleptic malignant syndrome, serotonin syndrome, or toxicological conditions, all these conditions can mimic sepsis, right? Thyrotoxicosis is another thing, all right? So in such conditions, if you're not sure whether it's sepsis or not, and if there is no shock, the guidelines are saying is that you can wait for up to 3 hours to evaluate the patient. Look for clues which, sorry, look for clues which is suggestive of sepsis or something else. All right. And if you are still suspecting sepsis, give antibiotics within the 3 hour window period. Okay. Now, rapid assessment of infectious versus non-infectious causes should be done within this 3 hour period. All right. Now, can we use other biomarkers? Already we said that CRP is not very specific for sepsis. Okay. So none of these guidelines are actually recommending to use CRP as a biomarker. What about procalcitonin? Procalcitonin is also not that sensitive or specific for diagnosing sepsis. Okay, so procalcitonin, what they are saying is that procalcitonin should not be used to decide whether to start antibiotics or not. Okay, now antibiotics, um, of course, if there is low likelihood of infection and there is no shock, we should not start these patients on antibiotics. Okay. Now, in suspected sepsis or septic shock, but unconfirmed infection, all right, you can start these patients on antibiotics, but continuously search for an alternative dose. And whenever you find that this is not due to an infection, there is no sepsis, you have to stop antibiotics immediately. Okay. Now, obtain appropriate blood culture or any other culture. Appropriate cultures have to be obtained, including blood culture, before giving antibiotics, provided that there shouldn't be any additional delay. So, maximum 45 minutes should be the time taken for taking these cultures. And after that, you should start these patients on antibiotics. If you are expecting a delay of more than 45 minutes to obtain these cultures, give antibiotics. All right. Now, what is the problem if you give unnecessary antibiotics? We all know this. There can be allergic or hypersensitivity reactions. There can be acute kidney injury. Thrombocytopenia can be the result. Clostridium difficile infection can occur. And of course, we know about antimicrobial resistance. Okay. Now, which antibiotics should be given if you diagnose or suspect sepsis? Now, we know that we have to give broad spectrum antibiotics, right? Should we cover for MRSA? So MRSA coverage should be given only if there is high risk for MRSA. For example, if the patient has prior history of MRSA infection, or we know that he has been colonized with MRSA, or if there is recent IV antibiotic use. Remember IV antibiotics. All right. Then history of recurrent skin infections or chronic wounds, presence of invasive devices, hemodialysis patients, recent hospital admission. Our patient has a history of recent hospital admission. Okay, usually within the last 3 months is the recommendation. Our patient had an admission within the last 1 month. Okay, then of course the severity of the illness also has to be considered. Now you can stop giving MRSA coverage if there is evidence of negative NAIRS or BAL MRSA PCR which is showing no signs of MRSA infection. You can stop the MRSA coverage. Okay. Now, whether we should cover for MDR organism, multi-drug resistant organisms. Okay. Now, if there is high risk for such organisms, the guideline recommends to use 2 gram-negative antibiotics empirically. Okay. But most often our settings, we do not usually practice this. We usually start them on one or a higher gram-negative coverage antibiotic. All right. So the recommendation is that if there is proven infection or colonization with antibiotic-resistant organisms within the preceding year, or if there is hospital or healthcare associated infection, whether the patient has received broad-spectrum antibiotics within the preceding 90 days, that is last 3 months, then concurrent use of selective digestive enzymes is there, or travel to a highly endemic country within the preceding 90 days. This is for the Western population. Okay. Then hospitalization abroad within the preceding 90 days, again for the Western population. All right. Now, once the causative organism as well as the susceptibility is known, then you don't need to have double coverage for gram-negative organisms. Okay. Then you need to have only a targeted therapy with a single agent. All right. Now, what about antifungals as well as antivirals? Should we start antifungals empirically? All right. Now, there was this trial called Empiricus trial that there is no advantage, there is no mortality benefit in starting antifungals empirically. But in high-risk patients, which is given in this table, this was taken from the SSC guidelines. All right, you can find it in the guideline. Okay, if there are high-risk conditions for fungal infection, you need to consider giving empirical antifungal therapy as well. For example, patients, neutropenic sepsis patients, okay, patients who are not achieving defervescence after 3 to 4 days of giving antibiotic coverage, appropriate antibiotic coverage, then you need to suspect additional of the patient is having a fungal septicemia. All right. Now, what about antiviral therapy? Viral septicemia is very less common, less than 4%, and this is usually due to influenza as well as SARS-CoV-2 virus. And we have separate guidelines for these kind of things, and I won't be discussing those things here. Now, in immunocompromised patients like renal transplant patients, you can have HSV or EBV or CMV or even adenovirus causing septicemia. All right. Now, in conditions like dengue, Ebola, or chikungunya, there is separate guidelines for those kind of things. So the SSC guidelines actually make no recommendations regarding antiviral therapy in the 2021 guidelines. Okay. Now, microbials, when you're using beta-lactam antibiotics, like any penicillins or piperacillin tazobactam, the guideline is recommending that, and there is a lot of good evidence that we should use prolonged infusions, all right, rather than giving them as boluses. Of course, the initial dose, the first dose should be given as a bolus. This is to attain the adequate drug level in the blood very quickly. All right. And after that, in order to maintain that level in the blood, we should be using prolonged infusions. For example, if you are giving piperacillin tazobactam every 6th hourly, the whole infusion should be given over a period of 6 hours. All right. And they are saying that it should be given at least taking half the time of the interval. So if you are giving every 6 hourly, at least you should be covering the initial 3 hours. Okay. So the better thing to do is give it through an infusion pump over the next 6 hours or even 8 hours if you are using an 8-hourly dosing medication. All right. Now, daily assess for de-escalation of antimicrobials is very important rather than using a fixed duration of therapy. Okay, earlier we had this practice of giving antibiotics for 14 days or even 21 days. That is not required and that is not recommended as well. We need to assess the condition of the patient every day. All right. And whenever we feel that this patient is improving, see, most of these patients, the infection might get controlled earlier. All right. If the organism is sensitive to the appropriate medication, infection can be controlled pretty pretty easily, I would say. Okay. All right. But the problem here in sepsis is the dysregulated immune response. Okay. Our dysregulated immunity is the main culprit here, which is damaging our own organs. All right. So that will take some time to recover, especially the kidneys, the lungs, ARDS patients. It will take some time. All right. And you shouldn't base um, antimicrobial therapy based on those findings only. All right. Now, de-escalation is very important. Antibiotic stewardship is a very important um, consideration in the practice of critical care. So de-escalation can be stopping of an unnecessary antibiotic as soon as the culture report shows that a particular antibiotic is only sensitive, then we should go for that antibiotic. Okay, we should be narrowing down the spectrum. All right. Changing to a narrow spectrum one is very important of de-escalation. Then early discontinuation if infection is ruled out. That's also part of the de-escalation practice. All right. Now, the duration of antibiotics, shorter duration of antimicrobial therapy is has shown to have equal efficacy to longer duration therapies. All right. So in pneumonia patients, at least 5 days is recommended, but maybe a maximum of 7 days might be enough. All right. Of course, it's everything is based on the condition of the patient. Okay. Now, is there any biomarkers that can help us to guide whether we can stop antibiotics or not? Procalcitonin is really good for this thing. Okay, procalcitonin and as well as clinical evaluation can help us to decide when to discontinue the antibiotics. Okay, in bracket here, I have put the recommendation, the strength of the recommendation. All these are weak recommendations because there is not much evidence to support these recommendations. Okay, now, our patient, we have started the patient on piperacillin tazobactam as well as vancomycin because she has a comorbidity, chronic bronchial asthma is there. She has diabetes, okay, as well as she had a recent hospital admission. Okay, so there is high risk of MDR pathogen here, and the patient is as well as MRSA infection also. So we are covering both. This patient is also admitted in the ICU with mechanical ventilatory support using non-invasive ventilation. So the antibiotic was given after taking the blood culture and sensitivity. Okay. And after a couple of days, we got the report and you can see the organism was identified as Pseudomonas species, which was sensitive to piperacillin tazobactam. So we stopped the patient from vancomycin. All right. So vancomycin was discontinued there. Okay. That is part of de-escalation therapy. Now, is antibiotics the magic bullet here, or is it not enough in all cases? Let's see another case. Okay, so this is a 88-year-old female. She is a non-case of CKD, diabetes, coronary artery disease, and she had a recent surgery of mastectomy for right carcinoma of breast. Okay, right breast carcinoma. All right, and this was 1 month back. Now she presented with decreased responsiveness and she has been having a history of fever with chills for the last 2 days. Okay, this is a video of the patient. She's completely unresponsive. And when you check her blood sugar, you can see that it's only 41 milligram per deciliter. All right. Now, this patient, after correcting the hypoglycemia, okay. And when we did a serial examination, when we rechecked her, she was having severe left-sided abdominal pain as well as renal ankle tenderness. Okay, now she is fully conscious and she is able to appreciate the pain. All right. So that is something very important. Always looking for underlying cause for the hypoglycemia. So this patient was having a fever with chills. So we were suspecting UTI. And when palpation we were able to find that this patient was having left-sided renal angle tenderness. So of course we were suspecting a pyelonephritis in this patient. Okay. And again, you can use the point of care ultrasound here. And you can see here, this is the right side, right kidney here. And you can see some hyperechoic shadows here. It might be difficult for you to make out initially if you are not using ultrasound um, in your emergency department or in the ICU. Okay, so that was suggestive that this patient was having emphysematous pyelonephritis. Okay, finding gas in the kidneys. All right. And on the left side, you can see that there was hydroureteral nephrosis as well as air shadows also you can see. Okay. So this patient was having some kind of obstruction also on the left side. All right. You can see the dilated ureter here, as well as the hydronephrosis here. Okay. So in this patient, we went straight away to get a CT KUB. So this is the use of having bedside ultrasonography. You don't have to initially go for an ultrasound examination and later go for a CT scan. All right. We straight away went to get a CT scan in the patient, and you can see the diagnosis of emphysematous pyelonephritis here bilaterally. This is the left kidney, and you can see the gas inside the kidney here. And this is the right side. You can see gas inside there as well. Okay. You can see the left kidney is also bulky because of the hydronephrosis. Okay. Now, in this patient, you can see she's also having metabolic acidosis, high anion cap metabolic acidosis. Of course, she's a CKD patient, and her CRP, you can see it is 162 milligram per liter. Normally, it should be less than 6 only. You can see the total count is also elevated. She's not having a very good control of her blood sugars. And you can see the platelet count, it is less than 1.5 lakhs. All right. So this patient is also having sepsis. Okay. Now you can see the creatinine here is 6.02, and the blood urea is also on the very high side. All right. It is 153. Her previous creatinine value was around only 2.5. Now it has been elevated to 6.02. And on urine examination, you can see there is numerous pus cells as well as RBCs there. All right. Now, does this patient require only antibiotics or something else? That's a question. Okay. Now, very important thing here is that we need to identify the source. We have identified the source. And whenever there is a collection of infection there, which is amenable to source control, we need to go for that. All right. So this patient wouldn't have improved just with antibiotics unless we relieve the obstruction in the left kidney there. Right. There was hydroureteral nephrosis, but you can see in the CT report, there is no evidence of calculus, but still there was some obstruction there. And you can see that this was the notes from our urologist after doing bilateral DJ stenting. Left side, he could not do DJ stenting. The guide wire could not be passed because of the obstruction. And initially, urethroskopy had to be done, followed by DJ stenting. Okay. And in urethroskopy, what was causing the obstruction there was a papillary necrotic bit. All right. So we know that diabetic patients, they can have papillary necrosis, and this can cause obstruction in the ureters. Okay, so the patient can have hydroureteral nephrosis, which can lead to pyelonephritis, and these kind of patients can high risk of diabetic patients, uncontrolled diabetes are having high risk for emphysematous pyelonephritis. Gas producing organisms could be there. Okay, like Klebsiella or Pseudomonas. All right, even E. coli. Okay. Now, that is very important. So just not antibiotics. Antibiotics alone may not be sufficient in most of these patients. And you need to identify whether these patients require source control as well. So the guidelines is recommending, SSC guidelines is recommending that identify infections that require source control and intervene as soon as possible, ideally within 6 to 12 hours. Our patient underwent DJ stenting, bilateral DJ stenting on the same day. And within a couple of days, the patient's condition improved and we were able to shift her from the ICU. Okay. Now, the common areas of source control include intra-abdominal abscesses, perforation peritonitis. We know that it's a surgical emergency. Then empyema, any closed cavity having pus inside, it's empyema. Then septic arthritis, ischemic bowel or volvulus, then cholangitis, then cholecystitis, pyelonephritis with obstruction or abscess, like in our patient. Okay, then necrotizing soft tissue infections, then implanted device infections, all right, like a central line, then, or even a pacemaker, then IV access devices. All these are source control devices. Okay, if these are the sites of infection, they have to be removed. All right. So procedures like drainage of synapses, debriding infected necrotic tissue, removal of potential infected device or vascular catheters, these have to be done. Okay. And if possible, use the least invasive procedure that is available. All right. Now, this is case 3. Okay, now let's move on to septic shock. Now, this is a patient with CLD and he's under our gastromedicine follow-up. The patient recently had ascitic fluid tapping, and now he came with complaints of fever as well as vomiting. Okay, fever wasn't that high because but he was having um, refractory vomiting for last 4 days, decreased food intake. He was not able to even drink anything. All right. And he was also having significant severe abdominal pain also. Okay. And you can see that we are doing a diagnostic ascitic fluid tapping here. And you can see the turbid color of the ascitic fluid here. And when we did the study of when we looked at the total count of the fluid, it was very much high of 11,231 with predominant neutrophils. Okay, so this was suggestive of SBP, spontaneous bacterial peritonitis. All right. Now, another important thing is that when the patient came to the emergency department, look at the vitals. He was having tachycardia and his blood pressure was on the lower side. The mean arterial pressure was only 58 and the BP was 80 over 47 only. All right. So we got a VPG for this patient. Even though lactate can be elevated in CLD patients, it won't be this high usually. All right. So the lactate was 5.8 in this patient. All right. And we were suspecting sepsis in this patient. And of course, the lactate is supportive of that here. Okay. He was having metabolic acidosis with a bicarbonate of 14 only. All right. Now let's learn about septic shock and management of septic shock. All right, we already learned that it is a subset of sepsis and how we diagnose it is by the requirement of vasopressor to maintain a MAP of 65 millimeter of mercury or higher, and the lactate should be more than 2 in the absence of hypovolemia. So in this patient, we need to evaluate whether this patient is having hypovolemia and we need to correct that first, okay, before calling it as septic shock, right? The lactate is high, but still we don't know about the mean arterial pressure at this point. Okay, so how should we go about with the fluid management? How should we correct the hypovolemia here? Of course, our patient has been continuously vomiting for last 4 days. He is not having any good fluid intake. We know that this patient is probably having hypovolemia and may tolerate some fluids. All right. So the SSC guidelines, it's actually recommending that if there is any patient having or suspected of having septic shock, should be given at least 30 ml per kilogram of IV crystalloid fluid within the first 3 hours of resuscitation. And this should be started within the first hour of recognition of sepsis in these patients. Okay. So at least 30 ml per kilogram. So if a patient is 60 kilogram, it should be actually the actual body weight that we are using. All right. Even though they are not recommending what kind of body weight should be used, whether it's predicted body weight or actual body weight, we'll be usually using the actual body weight, right? So if the patient is having 60 kg, we should be giving at least 1.8 liters of crystalloid within the first 3 hours. Okay, that's what the guideline is recommending. But since they have made this recommendation, a lot of controversy has been there. Because suppose if the patient is having CKD, okay, he is on maintenance dialysis, he has missed his dialysis for last couple of times, he's having signs of fluid overload, and whether the patient is having enough intake or not. If the patient is having signs of fluid overload, then you cannot give more fluids in these patients, right? Or if the patient is having severe heart failure and again signs of fluid overload, We shouldn't give patients, those kind of patients, even if they are having sepsis and septic shock, this much fluids. It can worsen the condition, right? So fluid, we need to be very careful, all right? Just like antibiotics, fluid stewardship is also a kind of practice in the ICUs as well as the emergency departments. Fluids are also medications and they have to be prescribed very carefully, okay? Because hyporesuscitation, hypoperfusion, or even hypovolemia is also problematic. We know that. And just like that, over-resuscitation with fluids, hypervolemia is also problematic. Hypovolemia has shown to increase cerebral edema in many of these patients. So sepsis patients, after giving a lot of fluids, they can go into uh, altered mental status because of cerebral edema. Many of these patients can develop ARDS. Okay. Then a lot of studies have shown that patients can develop abdominal compartment syndrome, hepatic compartment syndrome, renal compartment syndrome. Okay. Hypervolemia has shown to increase AKI. All right. So there is a lot of problems with overresuscitation. It has shown to increase mortality, especially in resource limited settings. You need to understand that most of these guidelines, I have already mentioned that, are produced, especially this guideline was made from Society for Critical Care Medicine in the USA. Okay, it's based in the United States. All right, well, there is adequate resources there. Okay, so even if the patient goes into fluid overload, they have the capability of managing these patients. Okay, using mechanical ventilations or even dialysis, they have the capability. But in resource limited settings, in countries, especially in India or in Africa, over resuscitation can be a really big problem. Okay, there was this trial called as FEAST trial, which was conducted in Africa in children having sepsis. And it was shown that over resuscitation or liberal fluid strategy was associated with very high mortality in these patients because they didn't have any supportive mechanism, even enough ICU beds to admit these kind of patients. Okay, so fluid stewardship is the way to go. All right. And what kind of fluid should we give? First line fluid for resuscitation should be crystalloids. So if there is obvious signs of hypovolemia, you can give fluids. Obvious signs of shock with hypovolemia, give fluids. All right. So if you are giving fluids, crystalloids should be given and not colloids, especially starch-containing colloids like HES. All right. In fact, HES has shown to increase the renal replacement therapy. It has shown to worsen acute kidney injury, cause acute kidney injury compared to crystalloids. HES is actually banned in many of the European countries also. Okay, so crystalloids is the ideal fluid or the first line fluid here for resuscitation. All right. Now, whether to go for balanced crystalloids like ringer lactate or plasmolite, or is normal saline adequate? A lot of trials have shown mixed results. And the latest evidence from the basic trial, which is one of the largest randomized trials, which was conducted recently, is showing that there is no much difference. You can use normal saline as well. So go for normal saline. All right. Now, what about colloids? Can we use any colloids? I have already mentioned that HCS should not be used. It is a strong recommendation that it should not be used. All right. Now, gelatin also should not be used. Gelatin is also a recent colloid which has came into the market, but it has shown to have no advantage over crystalloids. Okay. Now, albumin may be used. Okay, it is the only colloid that has been shown to have some kind of advantage. Actually, it doesn't have much advantage, but it can have a volume sparing effect. If you are giving too much normal saline, it can cause a lot of, it can cause hypochloremic metabolic acidosis along with the already high anion gap metabolic acidosis that we are having in septic shock. It can cause, if you give a lot of volume of normal saline, it can cause hypochloremic metabolic acidosis. And the chlorine is the worrying part. It can cause renal vasoconstriction and it might worsen the renal condition here also. So in such patients, you may give albumin, especially patients having hypoalbuminemia, like CLD patients, cirrhotic patients, you may consider giving albumin. Okay. Now, how to monitor these patients when you're giving fluid resuscitation? The recommendation is that for adults with sepsis as well as septic shock, use dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. See, heart rate, blood pressure, urine output are all useful. Okay. But for immediate fluid resuscitation, they are not very sensitive or specific. All right. Even if patients are having a low heart rate, they may not be fluid responsive. Even if they are having a low blood pressure, they may not be fluid responsive. All right. Then static parameters, it includes other parameters like central venous pressure. Okay. Then pulmonary capillary wedge pressure. Okay. Those are also not very good. All right. What are dynamic parameters? These include response to passive leg raise or a fluid bolus, using stroke volume variation, pulse pressure variation, or echocardiography where they are available. Okay, so these are some of the dynamic parameters. All right. Then lactate clearance may also be used, which I have already mentioned when we talked about lactate. A decrease in the lactate level is a sign of good resuscitation. But a recent study called the Andromeda Shock Trial actually showed that in resource limited settings where lactate is not available, it requires ABG or VBG, right? Where it is not available, you can even use clinical parameters like capillary refill time. It has shown to be just as effective as using lactate clearance. Okay, so any one of these may be used. Now, what about restrictive versus liberal fluid strategy in first 24 hours? Again, mixed evidence is there. So the guidelines make no recommendation whether to go for restrictive strategy or whether to go for liberal fluid strategy in the first 24 hours. All right. Now let's talk a little bit about what is dynamic parameters of fluid responsiveness. Okay. Now, all of you might have heard about EGDT. Your professors might have asked you about what is early goal-directed therapy or EGDT parameters. Okay. This was actually put forward in 2001 when sepsis was a big problem. All right. And the standard of care wasn't very good at that time. All right. The mortality was very high, around 40% just for sepsis also. Okay. At that time, a lot of researchers came out with this concept of early cold direct therapy, especially Rivers and others. John Rivers was one of the main researchers who came out with this concept. Okay. What they said this is that we need to target certain parameters. Okay. Like CVP, and it should be kept between 8 to 12 millimeter of mercury. So your recession, it should be in such a way. So you should give adequate fluids to bring the CVP to up to 8 to 12 millimeter mercury. So you can use either crystalloids or colloids. Remember, this was produced in 2001. This guideline was put forward in 2001. All right. Now, if CVP is achieved, you should use MAP also. All right. And you should maintain a MAP of more than 65 millimeter mercury and less than 90 millimeter of mercury. And if the fluids is not able to maintain the MAP, then you can use vasoactive agents. All right. Now, the other parameter that you should be measuring is something called as a central venous oxygen saturation. And it should be more than 70%. Okay. Now, SCVO2 is a marker of tissue hypoxia. Okay. Now, if it is less than 70%, it is suggestive of tissue hypoperfusion and tissue hypoxia. Right? So in that case, you may use inotropic agents or even transfuse the patient with RBCs if your hemoglobin is less than 7 gram per deciliter. All right. So these were the targets which the EGDT group or EGDT concept was putting forward. A CVP of 8 to 12 or a MAP of more than 65 as well as central venous oxygen saturation more than 70%. But continuous central venous oxygen saturation required a special device, all right, which was put just like this central line for continuously monitoring the central venous oxygen saturation. So a lot of studies later showed that actually there is no additional benefit of using a central venous oxygen saturation. A lot of trials like PROMISE trial, PROCESS trial, and ARISE trial, which were conducted and published between 2014 to 2016 period. Okay, they actually showed that there was no additional benefit of using the EGDT recommendation compared to the standard trial. All right. So you did not have to use central venous oxygen saturation for all these patients compared to conventional care. Okay. And CVP also was shown to be not that beneficial in predicting fluid responsiveness. Okay, so what do you mean by fluid responsiveness? See, when you give a fluid bolus, it should increase the cardiac output by at least 10%. That is called as fluid responsiveness. Okay, see, the whole purpose of giving IV fluids is to increase the cardiac output, right? So if you increase the stroke volume and the cardiac output, we are hoping that it will increase the tissue perfusion and correct the tissue hypoxia, which is the result of the septic shock, right? Okay, but the static variables like CVP, pulmonary artery wedge pressure, right ventricular end diastolic volume, or even left ventricular end diastolic volume, they are less predictive for fluid responsiveness. These are not very good parameters for fluid responsiveness. These are called as static parameters because even during inspiration and expiration, these parameters do not change. Okay, so if even if a CVP is on the lower side, we cannot say that this patient would be fluid responsive. Now, if a patient is having a high CVP also, that patient might be fluid responsive. Okay, so it was only 50% sensitive. CVP was found to be only 50% predictive of fluid responsiveness. All right, which is not at all good. All right. So now the recommendation is to go for dynamic parameters. Okay. Now, dynamic parameters use something called as the heart-lung interaction. We know that when we are breathing in, when we are inspiring, there is a negative pressure, negative intrathoracic pressure, right? That causes the venous return to come. So the cardiac output will increase. And when we are expiring, venous return decreases and cardiac output decreases. Now, the opposite happens during mechanical ventilation. Okay, so there is this fluctuation in the cardiac output between inspiration and expiration. All right, this is called the heart-lung interaction. Okay, with inspiration and expiration, there is variation in the cardiac output. Now, if this variation or if this difference between inspiration and expiration of some of these parameters is beyond a certain value, that means that this patient is fluid responsive. Okay, so if you think about it, during inspiration, it's a natural way of giving fluids, right? And if the cardiac output is improving during that time, that means that the patient will be fluid responsive. If you give a fluid bolus, this patient's cardiac output will increase. Okay, that's the principle. All right. Now, the problem is that why we are using this thing is that, see, we are giving fluids hoping that the stroke volume will increase and assuming that the heart is in the steep portion of the Frank-Starling curve here. That is, the heart is preload dependent. But in sepsis, there could be septic cardiomyopathy, and the heart could be in this phase here. All right, just like a failing heart, there won't be any steep phase. Okay, so the heart may not be preload dependent, and fluids may even be harmful in such patients. All right, as already mentioned, it may result in cerebral edema, ARDS, abdominal compartment syndrome, hepatic or even renal compartment syndrome. Okay. So dynamic variables, they can be divided into stroke volume derived parameters. It could be stroke volume as well as stroke volume derived parameters, or you can have non-stroke volume derived parameters. And there is another category called as preload distribution manuals, which include passive leg raising tests. Okay. Now, stroke volume parameters include stroke volume variation, pulse pressure variation, aortic flow variation, systolic pressure variation. Okay, don't think this is, I understand that this can be a bit overwhelming, but at least familiarize these kind of concepts. All right. Now, all these stroke volume derived parameters, they are not useful in spontaneously breathing patients as well as in arrhythmia. Okay, so they can be useful only in patients who are mechanically ventilated. And these patients have to have certain mechanical ventilation parameters set on the ventilator while assessing the stroke volume parameters. Okay. Now, non-stroke volume derived parameters, these include vena cava diameter, ventricular pre-ejection period. Now, preload distribution manuals include passive leg raising. Okay. Now, one of the most common dynamic variable that we are using is the pulse pressure variation. All right. And for this, you need to require an IABP monitoring. So an arterial line has to be obtained, and your monitor should have the capability for IABP measurement. Now it will be showing the arterial waveform in this manner. Now you can see that during inspiration, there will be a rise in the pulse pressure here. Okay, because there is an increase in the stroke volume here. All right. And during expiration, you can see there is a fall in the arterial waveform here. All right. So the difference is the pulse pressure variation. Okay. Now, if it is beyond a certain value, that is suggestive that this patient could be fluid responsive, that the heart is in the steep portion of the Frank-Starling curve and it is fluid or preload dependent. Okay, if you give fluids, there will be an increase in the cardiac output. All right. Now, stroke volume variation also uses pulse contour analysis. Then another non-invasive method which is being currently experimented is something called as blood variability index. It uses the pulse oximetry. All right. Just like the arterial waveforms in IABP measurement, you can have you will be seeing waveforms on the pulse oximeter also, right? Which also varies with inspiration and expiration. And this variation is called as blood variability index. Okay. Now, another, if you are asked a question that which is the best predictor of fluid responsiveness among stroke volume derived parameters, the answer would be something called as delta down. Just remember this term. All right. Now, if delta down is not there, then the best option would be pulse pressure variation. All right. Now, remember, these are among the stroke volume derived parameters. Among all the parameters, that includes stroke volume derived, non-stroke volume derived parameters, the best one would be something called as SVC collapsibility index. That is superior vena cava collapsibility index. But the problem is that for the measurement of this thing, you need transesophageal echo, which is not available in most of our ICUs. Okay. Now, these are the threshold values which predict fluid responsiveness. All right. You might get questions based on this. Okay. So delta down, more than 5 milliliter mercury. Remember at least the pulse pressure variation. It should be more than 12% to 13%. Some studies have shown that it should be more than 13%. So 12% or 13% would be the answer here. Okay. Now SVC collapsibility index, it should be more than 36%. Now IVC measurement is something that we use very commonly in the emergency department as well as ICUs because we have point of care ultrasound machine in most of the ICUs in the hospital. All right. And so IVC, if you are using, we can use in spontaneously breathing patients, we can look for something called as IVC collapsibility index. So during inspiration, the IVC will collapse and during expiration, it will expand. Okay. So this collapsibility index, if it is more than 50%, then that patient can be fluid responsive. Now in mechanically ventilated patients, the exact opposite happens, right? During inspiration, the IVC actually distends. So we are using something called as IVC distensibility index, and it should be more than 18%. Okay. Now, we have already mentioned the pitfall of using these dynamic measures that especially stroke volume derived parameters that the patient should be mechanical ventilated, right? And the patient shouldn't be having any arrhythmias. So what to do in spontaneously breathing patients or patients having arrhythmia on mechanical ventilation? What we can use is something called as passive leg raise test. Okay. Now, the concept behind passive leg raise is that we are giving a natural fluid bolus. Okay. See, instead of giving fluid boluses or fluids by elevation of the leg, we give a fluid bolus of about 400 to 700 ml. And the good thing is that this is reversible. Okay, so after elevation of the leg, we will see whether any of these parameters is changing. All right, so is there an increase in the cardiac output? So you can use any stroke volume variation or pulse pressure variation, and you can see whether these parameters are improving. Okay, and the good thing is that it's reversible. Anytime you can lower the leg as well as elevate the head end. All right. So any adverse effect of a fluid bolus can be negated by using the passive leg raise test. All right. Now, how to do it? Elevate the head end about 30 to 45 degree for about 45 seconds. After that, you need to have these kind of beds. All right. Make the patient in a supine position and elevate the leg end for 45 degrees for 45 seconds. All right, and see the response. Okay, you can use real-time measurements of cardiac output and to whether the patient and you can again recheck by doing this the opposite day also. Okay. Now, dynamic variables, there are a lot of um, studies happening in this area. Okay, some of the recent advantages include use of end expiratory occlusion test. Just remember or get familiarized with these sort of terms. Then you can use something called as a mini fluid challenge test, where you can give 100 ml of colloids over 1 minute, and you can measure the stroke volume here. All right. And if there is an increase in the stroke volume by more than 10%, it is predictive of fluid responsiveness. And passive leg raising also, it's also a new concept. Then tidal volume challenge test is also there. Okay. Now, this is just a algorithm that we use in the ICU. Now, if there is any patient with acute circulatory failure, whether first of all look for evidence of fluid loss, all right, or is the patient in an early phase of sepsis? If yes, you can give fluids. Okay, if there is evidence of hypovolemia, you can give fluids. All right. If the answer is no, then you need to think whether the patient is spontaneously breathing, whether he's having any cardiac arrhythmia, or whether the patient is having a low tidal volume or low lung compliance. If that is the case, then you need to use passive leg raising or end expiratory occlusion test or mini fluid challenge test. Okay. If none of this is present, you can use any of the stroke volume derived parameters. All right. Now, this is another important concept in ICU. Okay, the ROSE concept of fluid therapy. So initially, R is for resuscitation. Initially, you give liberal fluids to correct the tissue hypoperfusion here. All right, and after giving the initial fluid boluses, you need to optimize. You need to consider the risk versus benefit of again giving further fluid boluses. All right. Then after that, you have a stabilization phase. Okay, you do not give further fluids. If you need to maintain the perfusion, you will be using more of vasopressors in this stage. All right. So this is a late conservative fluid phase. Okay, this is mainly a restrictive approach during the stabilization phase. And of course, if there is any signs of fluid overload in the final evacuation phase, we will be removing any excess fluid. So if there is a positive fluid balance, we will be removing that once the patient is stable. Okay, this is called the evacuation phase. All right. So remember the concept of ROSE, ROSC. Okay. Now, in our patient, we actually gave the patient fluid boluses of about 1 liter because the patient has obvious evidence of hypovolemia. Patient has been vomiting continuously and no intake also for last 2 to 3 days. All right. But what we saw is that, and what we mostly see in many of these patients is that when we give crystalloids, one thing you need to understand is that only 25% is retained intravascularly. The rest is going into the interstitial space, right? Okay. Now, the theoretical advantage of using colloid is that it would be retained intravascularly. Almost the entire fluid will be retained intravascularly, and interstitial distribution is much less. That's why you need to give only less colloids. But in sepsis patients, what we are seeing is that all studies have shown is that there is no much of this volume sparing effect. Because the problem here is in sepsis itself is vascular permeability. There is a lot of vasodilatation, especially splanchnic vasodilatation and increased vascular permeability. So there is fluid leaking from everywhere, right? So it's a distributive shock in septic shock, right? So even if you give crystalloids or colloids, everything is getting leaked into the interstitial space. That is the reason for cerebral edema. That is the reason for abdominal compartment syndrome, renal compartment syndrome, and all the problems associated with overloading of these patients with fluids. Okay. Now, in I already mentioned that only 25% will be retained, right? But when you are giving a fluid bolus, initially all this fluid will be occupying the intravascular space. and in the next 30 minutes to 60 minutes time, it will get redistributed into the interstitial space. So when you give fluids, you can see that there will be an initial response. Okay, so the blood pressure might improve, the tachycardia might come down. But remember, usually this is going to be only a transient response. All right. Always monitor these patients very carefully. They can have, they can rebound back into the hypotensive phase after a few minutes of time, like 30 to 60 minutes. So this was the same thing that was seen in this patient as well. Okay. So after giving 1 liter of fluid, the blood pressure improved to MAP was more than 65. And after some time, again, he went into hypotension. Okay. MAP was around 58 only. So we started the patient on albumin as well. Okay, now this is one colloid in especially in CLD patients that can help to improve the blood pressure. But even after starting the albumin usually we are giving over 4 hours as an infusion. But so during that time, we started the patient on vasopressor, especially noradrenaline. So let's see what is the vasopressor that is recommended. In septic shock, target MAP of 65 millimeter of mercury and not higher. Okay, so vasopressors should be given targeting a MAP of 65 millimeter mercury and not higher. Because if you are aiming for a higher MAP, you will increase the dose of vasopressors and it can be associated with adverse effects, especially arrhythmias can occur. Okay, but higher MAP may reduce renal replacement therapy in chronic hypertensives. So if you know that the patient is a chronic hypertensive, then there might be a role for targeting a higher MAP, but never more than 90 millimeter of mercury. Okay. Now, the first line agent or first line vasopressor is, of course, norepinephrine, and it is a strong recommendation because there is a lot of evidence that it is much better than other vasopressors like dopamine or even epinephrine. Dopamine, it is less potent compared to norepinephrine, and it has a higher risk of arrhythmias, especially atrial fibrillation. Now, epinephrine is also associated with arrhythmias and it can impair splanchnic circulation and it can also increase the aerobic lactate production. That's why it is not the first line agents. That's why norepinephrine is the first line agent. Okay, so this is a chart from the SSC guideline. So use norepinephrine as the first line agent. You target a MAP of 65 millimeter of mercury and if possible, consider invasive monitoring of arterial blood pressure because this is much more reliable rather than non-invasive blood pressure monitoring. Okay. If this is not available, you have to rely on non-invasive blood pressure monitoring. All right. And one important thing is that you can start these vasopressors using a peripheral line. Earlier, when I used to do my residency, the practice was that all these patients should be started on vasopressors only after getting a central line. So vasopressors should be given only through central line. All right. But now there is a lot of studies coming that even peripheral access using a large IV cannula in a large vein can be safe. Okay, but it should be for a minimal period of time till you can get a central line. So you can start these patients on peripheral vasopressors. Okay. Now, if noradrenaline is not sufficient, okay, if very high doses of noradrenaline is required, you may consider adding a second vasopressor, which the recommendation is for vasopressin. All right. Now let's see about vasopressin. We know that it is an endogenous peptide hormone produced in the hypothalamus. It is stored and released from the pituitary, posterior pituitary, and in is that there is usually a relative vasopressin deficiency. And we can give vasopressin in a fixed dose of 0.3 units per minute. It's not based on weight. It's not something which we prescribe on weight based. Okay, usually we are giving a fixed dose of vasopressin because higher doses of vasopressin is associated with cardiac digital as well as splanchnic ischemia. A lot of trials have shown that, like Vanish trial, that it can reduce renal replacement therapy, and VAS trial has shown that adding vasopressin can have a catecholamine sparing effect. Okay, so a lot of studies have also shown that norepinephrine plus vasopressin has reduced mortality compared to norepinephrine alone. So when to add vasopressin is when you have a requirement of norepinephrine more than 0.25 to zero point 0.5 microgram per kilogram per minute. Okay. So this is the recommend add vasopressin. Now, if there is evidence of cardiac dysfunction like septic cardiomyopathy or myocarditis is also there, you may consider adding dobutamine. Okay, or you may switch the entire thing to epinephrine. Stop epinephrine. Okay, sorry, stop norepinephrine, and instead of that, you can use only epinephrine. Okay, but levosimendan. Okay, sorry about that. Levosimendan is not at all recommended. Now, what about ventilation? Now we are coming to just supportive cares. Main important things about sepsis and septic shock have been covered. Now, ventilation strategy, oxygen targets, conservative versus liberal, no recommendation is from the SSC guideline. But always a conservative or restrictive strategy is much better. All right. It's from an experience point of view, it's much better. Okay. Now, sepsis-induced hypoxemic respiratory failure, HFNC is usually preferred over NIV. Now, NIV versus intubation, there is again no recommendation. Now, of course, just like in ARDS, the lung protective ventilation strategy is what is recommended. In severe refractory cases, you may have to even go for extracorporeal life support. Now, what about the role of corticosteroids? See, suppose if you require very high doses of norepinephrine, all right. So if ongoing norepinephrine requirement is more than 4 hours after initiation and dose is more than 2.25 microgram per kilogram per minute, you may consider giving hydrocortisone because just like vasopressin deficiency, these patients can have cortisol deficiency as well because of sepsis itself. Okay. So hydrocortisone 50 milligram IV every 6 hourly is recommended. And studies have shown that it has shown to accelerate resolution of shock, has increased vasopressor-free days as well. Okay, but the side effect is, of course, it can increase neuromuscular weakness. Now, RBC transfusion, PRBC transfusion should be done using a restrictive strategy. Okay, so if hemoglobin is less than 7 only, this patient should be transfused, except if the patient is having an acute MI or if there is severe hypoxemia or if there is evidence of acute hemorrhage. Okay. Now, stress ulcer prophylaxis, all patients who have risk of GI bleeding, like if they are having coagulopathy, shock or CLD, those patients should be given stress ulcer prophylaxis. Venous thromboembolism prophylaxis, pharmacological prophylaxis using low molecular weight heparin is what is recommended. Now, mechanical prophylaxis may be used only if pharmacological therapy is contraindicated. Now, renal replacement therapy in if there is AKI, CRRT, or intermittent hemodialysis may be used. Both of them are equally effective. Glucose control is something very important in sepsis management or in any ICU patients. Glucose control is very important. So the recommendation is to target between 144 to 180. A very rigid control is not required because it can result in overshooting as well as hypoglycemia. All right. Then vitamin C is not recommended. Bicarbonate therapy should be given only if pH is less than 7.2 and AKI is present. Just for lactic acidosis, you should not be giving bicarbonate. All right. Now, nutrition, early enteral feeds within 72 hours, if possible, should be started. Okay, it has shown to have a lot of benefits. So this is something called as the 1 hour bundle. Okay, this is the last slide, which was published by the Surviving Sepsis Campaign guideline. All right. Earlier guidelines, SSC guidelines, they initially had 6 hour bundle, then they reduced it into 3 hour bundle. Sorry. Then they reduced it to 3 hour bundle. Now they have come up with something called as a 1 hour bundle, considering the emergency of sepsis, considering the what do you say, importance of starting everything very quickly. All right. So they are advising 5 things that should be done within 1 hour itself. First of all, you should measure lactate if you're suspecting sepsis or septic shock and obtain blood culture before giving antibiotics. Administer broad spectrum antibiotics within 1 hour and begin rapid administration of 30 ml per kilogram of fluid for hypotension, and start vasopressors if these patients are not fluid responsive, as well as to maintain a MAP more than 65 millimeter mercury. So these 5 things should be started within the first 1 hour. Okay. So I usually do not give many take-home points because everyone will have different their own take-home points, right? But these are the things which I learned when I manage sepsis as well as going through these guidelines. Okay, so always look out for sepsis because it is a very common medical emergency. You need to suspect sepsis whenever a patient comes to you with infection. You need to look out for that. All right. And you can use SIRS, SOPA score, as well as blood lactate to diagnose sepsis. Okay. Now, early antibiotics, and if possible, after taking culture samples, is recommended. And remember the antibiotic stewardship, choosing the right antibiotic, stopping the unnecessary antibiotics, as well as stopping antibiotics as soon as the patient is starting to recover. Okay. That source control is also very important, not just antibiotics, then fluid stewardship as well as vasopressors. We covered all these things today. I'm willing to take any questions. I know it has been kind of a long topic, but it's a very important topic, right? If there are any questions, I'll be happy to take them. Okay, thank you so much. So with that, we'll conclude the session. Good night, everyone, and happy wish you to all. Thank you.